welcome to the channel. Today, we'll be summarizing this article titled Sudden Cardiac Death and Myocardial Fibrosis Determined by Autopsy in Persons with HIV, published in the New England Journal of Medicine on June 17, 2021. First, a bit of background. Sudden cardiac death, or SCD, refers to a sudden cessation of cardiac activity with hemodynamic collapse, typically due to sustained ventricular tachyarrhythmias. Structural heart disease is a major risk factor, but SCD often kills individuals with no previous identified risks. According to the WHO, in the absence of other explanations, cardiac cause of death may be presumed if the death occurred within an hour of symptoms. Over 90% of SCDs occur out of hospital, and almost all are never investigated, so it's often a guess as to whether a sudden death was actually due to cardiac causes. Researchers have not made progress in discovering risk factors for sudden cardiac death because we previously mixed many non-cardiac conditions into the study in which SCD has been presumed. Given the ambiguity, a Californian research team decided to conduct a study to determine the precise incidence and causes of SCD via autopsy. Published in 2018, they found that 40% of deaths attributed to stated cardiac arrest were neither sudden nor unexpected. Nearly half of presumed SCDs were not due to arrhythmias, and half of sudden deaths attributed to cardiac conditions were actually due to other causes, including drug overdose, pulmonary embolism, stroke, infection, diabetic ketoacidosis, gastrointestinal bleed, renal failure, seizures, and aneurysm rupture. The same researchers previously published a study in 2012 investigating SCD in HIV-positive individuals, where they found that SCDs account for 86% of all cardiac deaths, and the mean SCD rate was 4.5-fold higher than expected, at 2.6 per 1,000 person-years. Note that the SCDs were presumed by convention and were not confirmed by autopsy. The Californian researchers hence decided to conduct a follow-up study to establish the incidence of sudden cardiac death and sudden death caused by arrhythmias as determined by autopsy in HIV-positive individuals. This was a post-mortem observational prospective case-control study conducted in the San Francisco area between February 2011 to September 2016. In these 5.5 years, the researchers prospectively identified all new deaths due to out-of-hospital cardiac arrest amongst persons 18 to 90 years of age with or without known HIV infection for comprehensive autopsy and toxicologic and histological testing. They compared the rates of presumed sudden cardiac death and sudden death caused by arrhythmias between the two groups. Secondary outcomes included establishing the alternative causes of death and their incidence, as well as any significant autopsy findings during toxicologic and histologic testing. And here are the results. Of the out-of-hospital cardiac arrest cases, or OCAs, surveyed, about 1 in 6 were HIV-positive individuals, and they were twice as likely to be labelled as dying from sudden cardiac death, according to WHO criteria. After pathological examination, only half of those presumed to be SCD were determined to die from arrhythmias in view of their associated coronary artery disease, damage or enlarged heart chambers, or pre-existing arrhythmic disease. HIV-positive individuals remain twice as likely to die from SCD as a general population, even after pathological examination. The coroners found that these individuals had higher levels of interstitial fibrosis in the myocardium. Other misdiagnosed causes of death include renal failure, infection, hemorrhage, and diabetic ketoacidosis. Significantly, 1/3 of sudden death initially attributed to cardiac causes amongst the HIV population instead resulted from drug overdoses. This study shows that HIV-positive individuals are twice as likely to die from cardiac causes compared to the general population, and that these individuals are more likely to have hearts compromised by fibrosis, a factor that may play a role in increasing their susceptibility to SCD. Similar fibrosis in lymph nodes, liver, and kidneys have been observed in previous HIV studies. The researchers hypothesized that this fibrosis may represent a systemic impact of chronic HIV infection. Chronic inflammation in HIV-infected individuals persists even in the setting of effectively treated and suppressed HIV disease. In turn, this ongoing inflammation seems to be strongly predictive of clinical events including overall mortality and cardiovascular events. It may hence be useful to identify at-risk individuals with the purpose of preventing sudden deaths amongst persons with HIV. Furthermore, therapeutic strategies to reduce fibrosis will be an important area for investigation moving forward. The study also found that one-third of sudden death initially attributed to cardiac causes amongst the HIV population instead resulted from drug overdoses, in which there was no apparent evidence of drug use at the scene. This implies that physicians should have a higher index of suspicion for drug overdose in out-of-hospital deaths of HIV-positive individuals. The study findings also further reinforce the point that current definitions of OHCA and SCD can still be improved. There are of course some caveats to this. Firstly, due to the small sample size of the study, it is difficult to generalize the findings to other populations. Secondly, only structural heart disease could be assessed via autopsy, hence cardiac rhythm disorders predisposing to lethal ventricular tachyarrhythmias, such as long QT syndrome and Brugada syndrome, will be missed. Thirdly, histologic determination of myocardial fibrosis may be prone to sampling error, depending on the thoroughness of the histopathologist. Hope you've learned something from this video. Please like and subscribe for more of such videos. Thank you.